Thank you so much, sir. We'll now move on to the next academic session. It's on bleeding and thromboembolism. Chairperson is Dr. Suvro Banerjee, Senior Consultant Interventional Cardiologist at Apollo, Kolkata. I'll request our organizer, Dr. Chandrakant sir, to please introduce our first speaker.
Right, so this is bleeding and thromboembolism. The last case was the same. So now let me request Dr. Sheila Sawant. She is the professor and head department of general medicine, Tata Memorial Hospital, Mumbai. Ma'am, the stage is all yours. Looking forward for presentation.
Thank you for the kind invitation. Okay. So the topic is predictors of recurrent VTE and bleeding in patients with cancer, a meta-analysis. One sec, yeah. Okay. Just since we are changing gears from cardiac toxicities to venous thromboembolism, I thought I'll give context before I go to the meta-analysis per se. We all know that cancer increases the risk of VTE 15-fold, and it is a highly heterogeneous condition because of the multiple risk factors, patient-related, cancer-related, the treatment-related factors which can cause cancer-associated thrombosis, and the impact it has on the patient in multiple ways as regards the cancer treatment or outcomes because of cancer thrombosis, where there would be increase in risk of bleeding and recurrent thrombosis. Thankfully, we have improved treatments. Like in 2003, the CLOT trial, it proved that LMWH was more effective than VKAs, and that changed the treatment of cancer-associated thrombosis to LMWH. And it was in 2018 to 20 when there were trials on DOACs in cancer-associated thrombosis, and it proved that they were as effective as LMWH. So the current guidelines recommend DOACs and LMWH as a treatment. It's a class 1A recommendation, both for the acute and the long-term phase and the extended phase. It is a 2A recommendation. So when a patient is diagnosed with cancer-associated thrombosis, there are a number of things which we have to consider with respect to the site of cancer. Is there any GI tract impairment, renal impairment, drug-drug interactions, and then a choice is made by the clinician as to what to start, a DOAC or a LMW. So basically it's a balanced decision between the DOAC and LMWH depending on the patient profile. All guidelines or most guidelines recommend a 6-month anticoagulation. Beyond 6 months, it is like if a patient has got active cancer or is on active cancer treatment, then it is suggested to continue the anticoagulation as long as the cancer is active. These are the various trials, ADAM-VT, Caravaggio, Hoxai-VT, and the SELECT trials on the DOACs in cancer. As you can see, the primary efficacy outcome is the recurrent VT, and safety outcome is major bleeding. Despite good anticoagulation, there still remains the challenge of recurrent VT. As we can see, it is anywhere between 3.4% to 11.3%, and a significant risk of major and clinically relevant non-major bleeding. So that is the challenge we have in cancer-associated thrombosis management. In our own data, 309 patients seen in a year, we have almost 31% patients on DOACs, and almost 17% patients are receiving therapy more than 6 months with a decent percentage of recurrent VT and bleeding. So the main challenge, as I said, is anticoagulation beyond 6 months. The duration of anticoagulation in these patients beyond 6 months is still unclear. There's a need for appropriate risk assessment model or for deciding which patient should receive longer treatment. Currently, what we have is a balance. We have to balance the bleeding risk, the cancer risk, the cancer-related risk, and the thrombotic risk in the patient and individualize the decision. That is what we do in our own clinic. With respect to the different models, the Ottawa score was formed in 2012. Though it did perform well in the derivation study, it could not be validated and externally validated, so it is not in use. A number of things like the D-dimer at the completion of therapy, residual VT also has been studied, but not really great results. There has been a study based on machine learning where they have put up these factors as the possible predictors for VT recurrence. Another meta-analysis published in 2025 itself based on the 4 RCTs. They have identified age, breast cancer, metastatic disease, treatment with DOAC, and DVT as the prediction factors, and they created a model, but it had only modest discrimination value. So this gets to our study. Sorry, and even with respect to bleeding, there are no scores which have been validated in cancer patients. The CAT bleed score was there, but it has not really performed well. Coming to the study, so basically it is predictors of recurrent VT and bleeding in patients with cancer. The key question is, what factors predict the risk of recurrent VT and anticoagulant-related bleeding in these patients? So they had a standard design followed as for meta-analysis with respect to design, database search, selection process, eligibility criteria, data extraction, risk bias assessment, and certainty of evidence. This is a statistical analysis which they used, and certain definitions as per the IST. This is the PRISMA flow diagram, and they have covered different regions, studies from North America, Europe, Asia. Recruitment period in the studies which are included were right from 1966 to 2020. So these are the results. With respect to recurrent VT, these were the prognostic factors. These X, age, history of VT, creatinine clearance, recent surgery, what was the site of DVT, the ECOG performance, the status, advanced cancer or not, cancer therapy which they received, cancer site. And with respect to recurrent VT, these were the findings. The history of VT, ECOG performance scale more than 0, advanced cancer, lung cancer, hepatobiliary cancers, pancreatic cancers, and GU cancers, they increase the risk of recurrent VT with high certainty. As regards recent surgery and breast cancer, there was a lower risk. This is the grades of certainty they have mentioned, so those with high certainty have been considered as significant risk factors. With respect to bleeding, again, age, history of bleeding in the past, anemia, renal function, liver dysfunction, ECOG performance, advanced cancer, cancer therapy, and cancer site has been considered. And this is the grade of certainty. It has been found, what they found is, with respect to increased risk of bleeding, history of bleeding, ECOG performance scale more than 2, advanced cancer, brain cancer, GI, GU, and prostate cancer, so found to have a high risk of bleeding. So basically, these prognostic factors which they have found lay the groundwork for a risk-adapted approach to anticoagulant treatment for cancer-associated VT. The clinicians can use these factors to inform their patients about the expected prognosis and incorporate these in shared decision-making discussions with the patient. Example, patient can be considered for a shorter duration of anticoagulation or a less intensive anticoagulation in those with low VT risk and high bleeding risk, vis-a-vis a longer duration with more intensive anticoagulation in a patient with a high recurrent VT risk with a low bleeding risk. And clinicians can incorporate these key prognostic factors with the traditional factors to facilitate individualized treatment decisions. The authors say that these future research should aim to validate these factors across diverse patient groups and enhance the understanding of the association in patients with cancer-associated VT. They can be, make further work on development of, or either development or revising the existing models with respect to prediction, and may inform future trials to ensure treatment efficacy and safety in high-risk patients. The strengths, basically, they had the RCTs as well as data from large nationwide cohort. They followed all the recommended guidelines. Limitations inherent to a meta-analysis. In addition, what they did not cover was the effect of different anticoagulants or different durations of anticoagulation. And the factors which they have found basically are non-modifiable. So at best, they will allow them to inform, the clinicians can inform the patient about the risk, but there's no intervention which can be done based on this. And most of the cohort had patients which were included at the beginning of anticoagulation, so it is unclear whether these can be applicable to patients who are completing anticoagulation. So the key findings, they are found with high certainty evidence for several association of several patient and cancer-related factors, such as previous history of VT, bleeding, advanced cancer, and cancer sites, which I have mentioned, with the risk of recurrent VT and bleeding. Factors identified in this meta-analysis should be carefully considered as a part of risk stratification framework when making decisions with respect to management of CAT. Cancer-associated thrombosis necessitates, this is most important, it necessitates a personalized approach in the treatment where individual risk factors and clinical context are carefully considered. Thank you.
Excellent talk, ma'am. So just to ask you a question, so what is the usual DOACs you use in your practice? Are you comfortable using in our cancer patients? Or
We are very selective in using DOACs. Basically, I mean, if it is a patient with a GI malignancy, a luminal malignancy, a patient, a GU malignancy who is likely to bleed, a patient with a potential, drug-drug interaction, even patients, if there's no drug interaction, but the chemo is likely to cause a lot of mucositis, vomiting, we're not comfortable. So we are highly selective. So if you see in my data, we are using only 30-35% patients on DOAC, because these are the challenges, because these are oral medications, you have to be sure that they are going to be effective. Also, patients who have undergone resection, like if you have a colon resection, you can give apixaban, but you cannot give rivaroxaban. If it's a stomach resection, it is different. So the absorption site is also important. So all those factors are considered before choosing a DOAC. But we use, apixaban has a lower risk of bleeding, so I'm more comfortable with that, but rivaroxaban, apixaban, both we have been using.
Yes, sir. So I think the panel, you are discussing in the panel discussion?
I think we'll discuss in the panel.
Okay. Right, sir.
Proceed.
Right, sir. Thank you, ma'am. Thanks so much for your wonderful talk. So now let's go to the bleeding risk prediction after myocardial infarction, integrating cancer data. So Dr. Rajat Kar, who is a consultant intervention cardiologist from NH Howrah.
Good afternoon, respected listeners. So today my topic of discussion is bleeding risk predictions after acute myocardial infarction, integrating the cancer data, the updated precise DAPT cancer score. So this is the paper which was published in ESC journal. The dual antiplatelet therapy is a key after heart attack or AMI and prevent clots, but it increases the risk of bleeding. Precise DAPT score is a score used to predict the bleeding risk and decide on DAPT duration, whether it will be carried on or for short duration. The gap that cancer patients have a high risk of both clotting and bleeding, but cancer is not included in the precise DAPT score. This means many high-risk cancer patients may not be identified, potentially getting longer duration of DAPT. The key question, does incorporating cancer as a predictor into the precise DAPT score improve its performance or not? The study aimed to create a new modified precise DAPT score that includes cancer to compare the new score's performance against the original score to see how this new score reclassifies cancer patients. And this was a UK-based study, and this was a large nationally linked to UK cohort, that is a MINAP and HES ONS. Population was studied more than 2 lakhs, and among them 4,500 had active cancer during the study. The primary outcome was major bleeding at 1 year. And this is the central picture which I am coming. So creating the new modified DAPT scores, the study created a new scores by adding cancer as a binary variable, that is cancer present yes or no, to the existing precise DAPT score. Original predictor was age, prior hemorrhage, creatinine clearance, hemoglobin levels, and new predictors age, prior hemorrhage, creatinine clearance, hemoglobin levels, and cancer yes or no. In the new model, the active cancer was a strong predictor of bleeding with a hazard ratio of more than 1.8. Now, the key finding that improved performance, the new modified precise DAPT score with a binary cancer variables was better at discriminating who would bleed. That is, the C static improved from 0.6 to 0.64. This improvement was also seen in patients without cancer. The C static was 0.63, meaning that score was not undermined for the general population. And the key finding 2, reclassifying cancer patients. This is the most critical finding, that new score reclassified the vast majority of cancer patients as a high bleeding risk. The original score, in the original DAPT score, only 65.5% cancer patients were classified as high bleeding risk. This left approximately 35% of the cancer patients classified as lower risk. And the new score, 94% of the cancer patients were correctly classified as high bleeding risk. So the new scores risk categories accurately reflected the bleeding rates at 1 year. That is a high bleeding risk. When the score is more than 25, the bleeding rate approximately more than 6% per year. And the key takeaway message that new score reclassified 21.6% of the cancer patients that who were classified as very low and low risk group into the higher risk categories, ensuring that they are no longer overlooked. And model validation that good risk scores must be calibrated, meaning its prediction matched the reality. The calibration curve for the new binary cancer score was excellent, and the observed bleeding rates closely matched to the expected rates. So did the specific cancer types matters? They again classified as the ordinal variable like the colon cancer, GIT cancer and other cancer. They are creating more complex ordinal score but did not improve the discrimination. The C static was still 0.64. So key implication, using the original precise DAPT score could lead to 29% of the cancer patient being undertreated for bleeding risk. The modified score is a simple, efficient tool to help clinicians make better decisions for their high risk group. Not all cancer patients are high bleeding risk, that is approximately 6% were still classified as moderate risk. The limitations of the study, the data on DAPT duration, anticoagulation and cancer treatments, chemo etc. was not available in this study. The study to be externally validated in the other population, that is only studied in the UK based population. So conclusion and takeaways, the adding cancer as a simple binary variable significantly improved the precise DAPT score. The original score classifies only 65% cancer patients as high bleeding risk, new score 94%. Trying to separate cancer by type does not add any value to and may harm the score performance. This updated score allows clinicians to more accurately identify bleeding risk in AMI patient with cancer, leading to more informed DAPT duration decision. Thank you, sir.
Excellent, Dr. Rajat. I think we can speak on the score in the panel discussion in interest of time. Thanks, Dr. Rajat. Now let me invite Dr. Anish. He's our colleague, consultant at medical oncology at Narayana, Howrah. So, low dose apixaban, reduced dose for longer duration. This is an NEJM paper which he will present.
So,
Yes,
good afternoon everyone. So I would like to thank ACOS, Dr. Vivek, Dr. Chandrakant for allowing me the opportunity to speak on this topic. So today my topic will be the recent article published in NEJM this year in March regarding the role of extended reduced dose apixaban for cancer associated VTE. So as previously said by ma'am also, that VTE is a common life threatening problem, especially in cancer patients, and the cancer can increase the risk of VTE by up to 9 to 15%. And in all patients of VTE, it is seen that up to 20% of these patients have cancer. And we can say that the etiology of cancer associated VTE is multifactorial. So it may be patient related like obesity, immobile or not, treatment related like the treatment used like bevacizumab used or not, any surgery linked to immobility, and cancer related regarding the specific sites of cancer have increased risk of VTE like pancreas, GI, etc. So the treatment of venous thromboembolism normally includes anticoagulants. Other than this, mechanical devices and thrombolytics may also be used sometimes. So this is the NCCN guideline for treatment of DVT. So we can see that normally anticoagulation is used. If it is contraindicated, then sometimes IVC filter can also be used. So coming to the background of this study, it was the APICAT study, apixaban in cancer associated thromboembolism. So as I said earlier that cancer patients at a higher risk of VT, and in these patients of cancer who develop VT, there is a higher chance of recurrence, and they also have an increased chance of bleeding complications as compared to patients who are not having malignancy. So initially all the trials recommended actually they assessed DVT, DOACs or LMWH for a period of initial 6 months. For example, in the for apixaban, the ADAM and the Caravaggio trial assessed LMWH versus apixaban for a period of 6 months, which led to non-inferiority. But however, guidelines also suggest that anticoagulation should be considered to continue as long as the cancer treatment is ongoing or the cancer is present. So for this prolonged treatment, there is limited data regarding the anticoagulation dosage and the use. So the APICAT trial, they aimed to check whether the role of reduced dose apixaban, that is 2.5 mg twice daily, was non-inferior to the actual dose which was used in the Caravaggio study, full dose, that is 5 mg BD, to prevent recurrent VT in these patients who have already previously received at least 6 months of anticoagulant therapy. So coming to the methodology, it was a prospective double-blind non-inferiority study. They included patients who had active cancer and VTE, had already completed 6 months of anticoagulation therapy, either DOAC or LMWH, and they did not develop any symptomatic recurrence of VTE during this period of 6 months. So these patients were randomly assigned to 1:1 ratio to apixaban 2.5 mg BD or 5 mg BD, and this was continued for a period of 12 months. And the primary outcomes was the incidence of fatal or non-fatal recurrent VTE, and the secondary outcomes was clinically relevant bleed, that is major or non-major. They classified major bleed as bleeding from any severe site like intracranial bleed, intraocular bleed, intraspinal bleed, etc. And the safety profile was also assessed. So as we can see in this slide that the median age of the patients in both the arms were around 67 months. This trial included around 1,700 odd patients. There was a male is to female ratio was around 43:50, and most of these patients had a platelet count more than 1 lakh and the creatinine clearance normal. So they were also divided between most of these patients had metastatic cancer, and sites of cancer were prostate, breast, colon, etc. So coming to the outcomes, the primary outcome was the incidence of VTE during the period of observation. So here we can see that in both these arms, there was around 2.1 versus 2.8% incidence of recurrence. So this was p-value was significant for non-inferiority. So for the secondary outcomes, that is for major bleeding, we can see that the incidence was around a bit less. 2.9 versus 4.3% in the reduced dose apixaban. The other outcomes, that death due to any cause, were almost similar. So the authors concluded that after adjusted subhazard ratio, the p-value was significant for non-inferiority regarding the reduced dose apixaban versus the full dose apixaban. For the secondary outcome, they also concluded that there was a lesser incidence of clinically relevant bleeding. So this was the hazard ratio, that is 0.76 with the p-value significant for non-inferiority for recurrence. So the authors concluded that reduced dose apixaban was non-inferior to a full dose apixaban. The incidence of relevant bleeding was lower with the reduced dose apixaban, and the major bleeding also appeared to be lower. However, they had certain limitations. For example, in France, they did not allow for any ethnic or race stratification. Also, another caveat is that there is no data for anticoagulation continuing beyond this 12 months, because as we now know that patients on multiple agents now survive for many years. So for above 12 months, so we do not have any good data regarding whether it should be continued on this dose or not. So thank you.
Excellent talk, Dr. Anish. I think you quickly went through the data. Now let's go to the next session. Let me take the pleasure of inviting Dr. Shubhra Roy Chowdhury. He is a Director of Endovascular and Intervention Radiology across the NH Group of Hospitals, Kolkata. It has been a pleasure working with him in the department, and to have him in the department is a real pleasure. So over to you, sir. The stage is all yours.
Thank you, Dr. Chandrakant, and thank you, Vivek, and the medical oncology team. It's always a great pleasure. Our MDT is a fun place. I can assure you that whoever comes from outside would love to see what happens in our MDT. So I've been asked to talk about two different things. One is cancer-related bleeding, and one is cancer-related thromboembolism. So, sorry. Oops. Are we on play? Okay, all right. So, so as an interventionist, we sit in the middle of the hospital. Okay, we deal with the neurosciences, cardiovascular, GI surgeons, chest, thoracic, gynecology, renal physicians, but very importantly, we also sit with the oncologists. I know that IO is nowadays called immune oncology, but you would remember that 10, 15 years ago, IO was supposed to be interventional oncology and not immune oncology. So it is regarded to be the fourth pillar of oncology. And actually, in spite of our marketing team not recognizing it such, but it happens to be the fourth pillar of oncology. And the reason why it does is because both in the emergency and in the elective setting, IR stands in the middle of all the services, because using CT, ultrasound, MR, and fluoro, using these basic techniques of embolization, ablation, needle-directed procedures, and plumbing, putting balloons and stents, you are a jack of all trades. But just using these four basic techniques across the body, across the oncological spectrum, you can make a patient's life better. You can be a welder, because you can go and ablate a focal lesion in the liver or somewhere else. You can be a plumber, where you can open a tube, which can be a bile duct or which can be an artery. It's a tube. So you access, you cross, and you deliver. The principles are the same. This is a stent. Or if the other job of plumbing, if it's leaking too much, you go and tighten the screw. So you go and stop a bleeding. Or you are a gardener. If there is a weed in your garden, you go and you guys do poison all over the body. We do focally, locally. We go and put the poison so that we can kill the appropriate stuff. So this is a typical drug-eluting bead taste in a patient with HCC. So I just wanted to give you this because, although my talk will be all over the place, because it will be different cases all over the body, the reason why it is unified is because it is these four basic techniques that you use all over the body. So, bleeding. Why there is more bleeding? You can have a vascular erosion from cancer progression, increased vascularity and HCC hanging out of a liver and bleeding. You can have a post-operative complication. You can have radiation-induced changes like cystitis, proctitis, etc. And of course, we are all heard about anticoagulation, why we should put them on anticoagulation. But the anticoagulation itself can be a cause of bleeding, typically retroperitoneal bleeding. And if you turn the coin upside down, then you have thrombosis, because of course cancer has increased thrombogenicity. There can be compression of venous conduits. Patients may have prolonged immobility. There can be thrombosis related to devices that we put. We put lines and stuff, so there can be thrombosis related to that, and not to mention drugs, and one drug was mentioned earlier today. So you see, this is the basic slide, and then I'm just going to show you some cases, because I was just going to show you the application of these principles. Here is a patient who had a Whipple surgery done, and a classic site of a Whipple's bleed is a GDA stump leak. And you can see the GDA stump. My arrow comes? No, okay. You can see the GDA stump, and the GDA stump has got the pseudoaneurysm on the right-hand picture there. And, sorry, oops. So I'm not a PowerPoint person. And then you go super selective into this GDA aneurysm, and then you put a glue focally to fill that up. So, and then you save that patient from the bleed. Here is a patient who has a TURBT and is bleeding from the bladder wall. And you can see here, again, a small pseudoaneurysm, again, inferior vesical artery, super selective, microcatheter, go and put some coils and stop it. Here is a problem that we actually deal with not that infrequently. In fact, we have the largest series in India of 26 cases of radiation cystitis. So here is very subtle. You see the bladder wall thickening as we go towards the superior part of the bladder with increased vascularity. So we can go into these vessels and, very fine catheter, this fine vascularity. It's like chopping the hair off at the barber. You just prune like the tree in a winter appearance. You just prune it down so that you stop that bleeding. So this is radiation cystitis. Head and neck, carotid blowout, or this is not something very common, but we do see once in a while that as the cancer progresses in the head and neck, you can have focal bleeding into the oral cavity or the nasal cavity. And a good CT angio will pick up that tiny little pseudoaneurysm there that you can see from the sphenopalatine, and then you can go and embolize that. Now, this is a case from last week, and I just wanted to show you this. This is a lady, 42-year-old, lovely, PS0, original. She had a cyst in her rectovaginal septum. She had an original operation in Singapore, and then the second one in one of our next door hospitals. And then she presents with this 9 centimeter mass. You saw there, this big 9 centimeter mass in the basically in the pelvis. So there you are. You can see that large 9 centimeter mass. She's bleeding. She has got this pelvic pain, and she's now bleeding per vagina. 2 hospital admissions in the last month. Hemoglobin down to 6.5. So this has already been embolized elsewhere twice, and is rebled because, see, if you're not going to deal with the primary tumor, it's going to recruit vessels again. So here we took a strategy, and this is, I'm told that largest numbers of needles used in cryo in India. So here are 7 cryo needles that has been put. You can see it's like a grid. So we put the cryo needles, and I mean, she's still, and this is the ablation volume. See, look at our cryo needles and look at the size of the ablation volume of a twice operated recurrent pelvic mass, completely treated, hopefully saving the vagina, saving the urethra, saving the bladder. I can only tell you that a bit later. But so that's bleeding. Just coming very quickly to thrombus. We have already been through these data, but high incidence of ETE, general population, it's about at least 5 times. Our good lady said it's 9 times. It could be that much in cancer. But if you look at the other aspect of it, that once you get the thrombosis, the cancer-associated thrombosis has a worse survival than non-cancer-associated thrombosis. If you get a PE, the likelihood that you will get a thrombolysis and adequate recanalization is less in patients with cancer than if they're not without cancer. So if you look at India per se, you can see that, you know, the 8.3 of all total malignancy-associated thrombus, VTE associated visits, the patients had cancer. So even in India, I think that the data is reproduced of what we see. Okay, sorry, I probably jumped a slide, but these are the slides that I think Vivek is going to show you in the subsequent panel. But I think it has been done a number of times that cancer-associated thrombosis, now there is level 1A evidence that it can be treated by a DOAC or low molecular weight heparin. Both are 1A indications. Now, whether there are some subsequent stratification studies that show that DOAC may be better than low molecular weight heparin, but these are industry-driven studies, so you have to be a little bit careful about interpreting the data. But put it to you this way, that at least from VKA, we have moved to DOAC and LMWH is no doubt. Okay, so I have to run. And you know, these again, I say industry-related study, also in reduction of the risk of recurrence, and also to restart the rivaroxaban quicker after stopping. Don't wait for, suppose you've done a prostate biopsy or something like that, don't stop it for as long. So these are all the new guidelines that are coming in. So I'm just going to touch one line on IVC filter, because this is a common misconception that people with a large volume of thrombus in the iliac or IVC, they are often asked for an IVC filter. We get the request. So the indication of IVC filter is very clear. Anticoagulation is contraindicated. If anticoagulation is contraindicated, it does not matter how much thrombus there is, it is not indicated, number one. Or if there is proven progression of thrombus in spite of adequate anticoagulation. Each of those words are important. Because how do we prove all the time that it is adequate? Because oftentimes the INR is 1.2 and then that is not adequate anticoagulation. So, and of course it can be placed without any additional risk. However, in pancreatic cancer, we went through this phase where we were electively putting those in. That's all rubbish. It doesn't increase any benefit. Even if you retrieve the filters, you have to understand that patients with cancer, oftentimes the filters are left behind. And if they're left behind, they can be a dangerous device. So therefore, I don't think that we should use it willy-nilly. So with that, I'm just going to show you last minute, honestly. So large volume thrombus, this used to be our every Friday case in the UK, not so much in this country because radiation does do a lot of good things. So this is a facial swelling in a patient with SVC syndrome. Honestly, a 10-minute job for us. Come from the arm, cross, put a stent and done. Okay, so this is a relatively easy thing that we do. Now this, on the other hand, is a much more interesting case. So this is a case Vivek might remember. This is a 76-year-old gentleman who came in with an acute onset of swelling of the right lower limb. I'll show you the movie in a second. Hopefully it will play. Okay. So as you can see, you'll see the movie in a second. So you can appreciate that there is a large prostatic mass invading into the bladder. Look at the discrepancy between the right and the left limb size. And had an episode of swelling, presented like that, and high suspicion on DRE that there is a prostate cancer. So this patient was actually diagnosed with the DVT and was on anticoagulation, and then the anticoagulation was, apixaban was stopped to the prostate biopsy. Okay, so guys, I'm messing up on here. Okay. So just to give you some more pictures here, so you can see that large pelvic mass invading the bladder, and then also the compressive nodes onto the iliac veins, and there is thrombus extending all the way to the IVC. Some more pictures, a very vascular prostate. So you've got and this patient is now bleeding because, so this is not an uncommon problem. You've got thrombus and you've got bleeding. So the strategy that we have is very simple. Go and embolize a bleed and put the patient on anticoagulation. If the patient has got marked symptoms, then do something to create the channel open. So here, large mass pressing on the vein, causing the DVT. So my step one approach is, I can't read, is to place a filter, because this is indeed a very large volume thrombus. Also, I cannot give anticoagulation. Okay, so place a filter, then embolize the bleeder, and then clear the thrombus. 1, 2, 3. Okay, so here is an IVC filter being placed. Here is a prostatic artery embolization being done to stop the hematuria. Right followed by left. I won't go into the technique. There was some coil protection and all that. So microcatheter, we have done this. Now we have embolized the prostatic artery very nicely. Bleeding has stopped. Same sitting. Prone patient. Access into the popliteal vein. Cross the blockage. Use your angiojet or your penumbra devices to clear the thrombus, like so. So you clear the thrombus, do some TPA, look at the state of the vein. See, the vein is now open, but it will not stay open. You do an angioplasty at the iliac vein, and you put a stent. Okay. Now this patient will have to remain on anticoagulation subsequently, but now with a less swollen leg, not bleeding, and hopefully continuing on with the existing oncological treatment. Thank you very much for your attention.
Excellent talk, sir. I think we will have panel discussion and we will have more discussion on intervention. Right, so Dr. Vivek will take up the panel discussion right now. Let me invite all the panelists.
Yeah.
Shubhra sir, you can stay on stage. Yeah. Dr. Shirish sir, you can be on there. Dr. Amit Sharma, my colleague from Narayana Hospital. Sheila ma'am, you can be on stage.
Yeah, so very quickly, we're going to wrap up this session. I won't take much time. Let us come to this case. A 42-year-old male, no comorbidities, non-smoker, diagnosed metastatic adenocarcinoma lung, right lung mass with bilateral small nodules, mediastinal nodes, and brain mets, and some bone mets. And this patient presented initially with shortness of breathing, right-sided mild chest pain and mild headache. We worked the patient up. There was no targetable mutation. PDL1 was negative. There was normal baseline workup. And patient was started on PEM carbo palliative chemotherapy and was planned for a subsequent whole brain radiotherapy. And right after the patient completed chemotherapy in daycare, day 1, what happens is that by the time the patient was planned to be discharged from daycare, the patient presented with severe breathlessness. So, Dr. Sirish, has this situation, occurred to you? You give a chemotherapy and suddenly you see the patient is having a lot of breathlessness, tachycardia, and how would you, sort of interpret this situation? Right after chemotherapy in a patient of, lung cancer or an ovarian cancer or,
We see this quite often in a small cell lung cancer where we suspect tumor lysis. That is one. But in NSCLC is very unusual. But that could be a hiding thrombus somewhere in the lower limb could be, and that must have gone up maybe.
Correct. So what was clear, to us that we admitted the patient, we performed the acute SOB panel that, usually goes in our hospital. The D dimer was very high. Echocardiography did show some amount of, right-sided increased pulmonary hypertension. And then we did a CTPA immediately at night, and it was confirmed that there is a pulmonary embolism in this patient. So this is one of the scenarios. So I'd come to Dr. Amit. Dr. Amit, in your newly diagnosed cancer patient in the OPD, do you always assess for this VTE risk before you start anti-cancer treatment? Do you do that in your routine practice?
Yes, we actually not at exactly the score as Khorana score, to be very honest, but we have a very quick assessment of the patient, that what is the patient's cancer site, what is the overall blood counts, platelet counts, whether he has a previous history of VTE. There are certain cancers where we suspect that. So where there is a very quick assessment that this patient can maybe a higher risk of future VTE.
Correct. I'd bring in maybe one of the other medical oncologists. Dr. Bharat is there. Dr. Bharat, in your routine OPD ambulatory patients coming to you for cancer treatment, do you look at their VTE risk every time and to preempt some of these patients?
Hello. So naturally, when we see patient as a medicine, not as an oncologist, we tend to take the history about the comorbidities. And at the back of mind, we are now calculating that risk eventually, be it a geriatric patient, young patient. And clinical examination is very, very important. I have not lost that art of examining the patient in the era of PET, CT, MRI, make sure that we touch the patient. And everybody is doing that. So nobody is keeping a separate record of thrombotic risk, but yes, sometimes you go and palpate the dorsality also, every other patient. So that is very important. And this is what we have been taught.
Yes. So, Dr. Sirish, in your OPD, I'm not talking about IPD, because we all know cancer patients, IPD, sick, they are non-ambulatory. We all instantly think about VTE prophylaxis, and I think this is something that across hospitals everybody has adopting this. There are even the nurses are adopting this, and this is even incorporated into the risk assessment scores in the hospital management. But what about the OPD? The entire decision depends upon the oncologist, and how many times it has happened in your ambulatory OPD patient you have started an anticoagulant because you are suspecting that this patient is at a higher risk for subsequent VTE.
So for a prophylaxis?
Yes. And when do you want to start it? That is what I'm saying, that in the OPD.
Bharat said if there's a previous history, then of course those are the candidates. Otherwise, not routinely, no.
Correct.
Even if it's like a pancreatic cancer or metastasis, I would not still start.
Correct. So we all know, Amit did highlight all the different patient-specific, risk factors, the cancer-specific risk factors, where there are primaries which are very high risk, and there are cancers with high risk, histologies, stage of the disease, and then the treatment related factors that can further increase the risk. And yes, there is a specific risk stratification score, Khorana score, and this is the formal risk stratification that actually needs to be done for every cancer patient in the OPD. And surprisingly, what I feel is that if we do it in each and every patient, then probably we would be diagnosing some more 30 or 40% patients who are at a higher risk that we are not preemptively putting them. So a specialized clinic is sometimes very important in these matters. Yes, Dr. Bharat.
Important is to understand the drug-drug interactions. So when you send across the specialty and somebody starts the anticoagulation, we have been using TKIs for lung cancer and CML. One has to make sure, because you can't remember each and every interaction. There are apps and AI is going to incorporate the data. I think that is very important rather than just starting the drug. Because these oral drugs, patient go home. Sometimes they get VFib, sometimes get the embolism. something happening in the hospital can be managed with the multidisciplines, but something happening at home, like bleeding from the GI thing, when you start aspirin and the apixaban or anticoagulants. So these things are very, very important, and the patient education is more important rather than because patient comes to us for 5 minutes, 10 minutes, 15 minutes, but they stay home and in the community. So I think yesterday somebody was talking, the general physicians in the community need to be made more aware, because it is the family physician, it is the internal medicine guy who can look after all these things. Because when it comes to oncologist or to cardiologist, we are just limited to that particular specialty.
Yeah, and one more query I have with this, Duak. I mean, when we check on drug interaction, calculate what the app is, it shows safe. But when we go to inlet or when we go to that specific drug, they show there is an interaction.
Yes,
so
yes. I think
when to use the drug interaction? I mean, how to check the drug interaction? Because when you put on that Google Kai checker and it says no. But if you go to individual specific Duak and check and other drugs, there is an interaction.
Yeah, I think, ma'am, you are correct that these are issues that we have to deal, especially when we are using oral and anticoagulants. But checking drug interaction is something that is essential. But what is the best way about it is is difficult. We all are using different kinds of apps, and maybe this is something outside the scope of this discussion. So we'll quickly come to Dr. Sheila as to madam. Yes. These patients who are having cancer, higher risk for VT, but also at risk of bleeding. Let's take this lung cancer patient who can have hemoptysis, but then, is also at a higher risk for thrombosis. So how do you actually realistically counsel these patients when you explain, start them on prophylactic anticoagulants?
Hello, can you hear me?
Yeah, yes, ma'am.
So, except for the myeloma patients where people receive prophylactic anticoagulation, as such, in general, it is not a common practice in our institute. And when I interacted with faculty abroad also, even though the corona score is good, it is not really used so much.
Yes, yes.
It is a reality that practically, maybe they have made the score, but the oncologists there wouldn't really be using it. So we should not go by that. Occasional case, for example, I have just recently completed treatment of a patient, say endometrium, for example. She's completed a therapy, then she comes with a recurrence. Then my oncologist, like Dr. Ghosh, will say, what about this? So this is the patient I would put on a prophylactic dose. So prophylaxis as such, by and far, we really don't use so much. Myeloma patients, our hemato-oncologists do as per their score.
Yeah, Dr. Shuvro, so Khurana score, of more than 3 was initially being thought equal or more than 3 as, the indication. You start patient on prophylactic anticoagulant. There is no existing VT proven yet. And then you have the guidelines being modified, and now actually most trials are even using it at a lesser score of, 2 or more. So, but
See,
madam clearly said that if you talk about oncologists, you see that so much less in practice, that although, retrospectively when you go and check, yes, this patient was at a higher score, probably should have been started, not started. So how do you see that?
So the point is that you see, it's the same story everywhere, right? That trial scenarios versus real life scenarios are different.
And these
so I
trials
think
have actually shown less incidence.
It makes
of
a difference. So maybe we should change practice. But what I'm saying is that you heard all the senior oncologists speak to say that they mentally do some sort of a maths. That could this patient require something, but whether we are actually actioning that to actually start them on 2.5 as he showed in that study, the APICAT study, 2.5 apixaban BD in a patient with a pancreatic cancer in whom all the other scores and Khurana score is high. Should we actually in the OPD start them on 2.5? Maybe we should change practice.
Correct. So I think one of the key messages that probably goes is that yes, a formal risk stratification is something that is essential in our OPD, and probably more 20 or 30% patients we can improve their quality of life, decreased sort of morbidity and improved survival, in more compliance to cancer treatment when you
so why it is also important is that of all the cancer related deaths, I got this number whilst I was reading up for this, is 25 to 30% of deaths are VTE related. Is the second commonest cause after cancer progression. So So then is it not important
I
to?
think it is still underdiagnosed maybe.
So again, Vivek, the validation of Quran is not for the IOs. That's another thing.
Yeah, correct.
So
So
if we are
this
using
is
IOs.
not for the oral ones, but I agree. Sir, maybe I'll start with you again. As to suppose when there is a risk, so what would you prefer to start? Anyone can take, yeah, maybe Dr. Shuvro, as to what is your choice of starting. Would you want to start all on LMWH, or you want to start on the DOACs? And again, what is the dose that would you prefer?
So if you would send the patient to me, I would see far less patients as such. But yes, of course, as a primary clinician in oncology, sometimes I will see patients or patients coming for me for swelling of the legs, etc. Yes, if the patient has got cancer, and if I think I am going to start, given the recent studies, we would start them now on DOACs. If the patient is an inpatient, then maybe 20 milligram Clexane or low molecular weight heparin is a standard dose that we would do for our patients that are admitted. For OPD, taking Clexane, not impossible, but slightly difficult. So, DOAC.
Correct. Dr. Amit, what about the precautions? So do all patients would you want to start DOAC, or there are some patients where you would be very cautious or not go for DOACs?
Madam answered it very nicely. In DOAC, some conditions like some cancers like GI cancer, especially this luminal type, they have more chances of having bleeding risk. So in those cases, maybe I will start with the low molecular weight heparin, and then I will assess later on. But I think there are certain GI cancers, especially the luminal, and especially those patients who are unresectable GI cancers. So those patients may have some problem with DOACs.
Correct. So also, there are issues regarding renal function, liver function, that all
of
these.
Of course, all these things need to be.
Correct. So what about warfarin? Sir, I would come to Dr. Sheila. That madam, we had this patient of metastatic colorectal cancer, history of an aortic valve replacement with a prosthetic valve, already on warfarin, and now this patient is come to us for starting systemic therapy. So should we continue warfarin, or can we change to DOACs? And my cardiologist say that no, we can't. But what would you do?
I would totally agree with your cardiologist, because when it is AVR, MVR, any valve replacement, it has to be warfarin. If not warfarin, it has to be LMWH. DOAC has no role. You should never even try to do that. Very clear. I mean, there is no doubt about it. DOAC, it's like, how in APLA you will not give DOAC. It's like if you have a valve, you have a prosthetic valve, metallic especially, there is no role for DOAC. Clear.
Rajat or Dr. Pandey, is there not a study recently of the safety of DOAC in valve replacement? There is.
As many cardiologists I asked, no one, the same answer as ma'am, that if you are not comfortable with VAF, you put on low molecular weight heparin.
So whichever patients who come
DOAC.
either with MVR, AVR in TMH, we shift them to LMWH, manage the entire chemotherapy with that. Once they are through that, then we shift back, overlap and shift to VK.
Correct. So the message is that DOAC is not for everyone. There are patients who would probably you would not start on DOAC. Now coming to this patient, the same patient. Now another question is, when do we restart the treatment? And again, maybe Sheila madam can address, or some cardiologists can address that. Patient has already had a pulmonary embolism. I gave one cycle of chemo, patient immediately had a pulmonary embolism. I started patient on initially on low molecular weight heparin, discharged on DOAC. Then, when should we restart the chemo in this kind of a patient? And yes, I think this patient is definitely at a higher risk of a recurrent VTE. But what is the optimal time to restart the chemotherapy?
Immediately. There is nothing like there is no window period to wait. You start the LMWH, you start the cancer treatment, because cancer is the cause of the thrombosis.
Correct. So the next, another message that I want to say is that the anti-cancer treatment should not be delayed.
No interruptions, no delay.
The next cycle of chemotherapy should be on time, irrespective of the pulmonary embolism. So pulmonary embolism has occurred, you have started DOAC, but there is no such. So again, madam, Another thing is that you know, often you see these patients having severe breathlessness, and I would come to Dr. Shuvro as to, is there a role for thrombolysis in these patients? You know, we had this patient who was severely, you know, breathless even when the second cycle was due, and patient was still on homebound oxygen. He was saying that, sir, I cannot just go to toilet also, or just walk. I have to be sitting, because slightest of movement I start having breathlessness, and patient is not having any effusion, patient is not having any infection. It is pulmonary embolism only which is the reason. Now, in such a situation, is there a role of thrombolysis?
Well, I'll tell you. So if if the echo says that there is a significant right heart strain, PA pressures are significantly high, let's say above 40, 45, and you are saying that all other causes have been excluded, and there is an obstructing lesion in the pulmonary artery, the answer is probably yes. But let me just qualify that the indication for intervention in pulmonary embolism that is out there in our literature is based on the severity of the presentation, not on the subsequent shortness of breath. So our criteria are tachycardia more than 100, systolic blood pressure less than 100, and high, and you know, pro BNP high and trop-I, high. Those are our criteria more in the acute setting. Now what you are saying is in the 6-week setting of PE with a thrombus, now we have mechanical devices that can remove that thrombus, yes. But if you ask me, can I help that patient? Yes, I can. Is it in the guideline? Perhaps not.
Yeah. So another important message that, you know, what I can drive from this panel is that yes, seek help of your intervention radiologist when, you know, you have this situation, because probably your intervention radiologist may help. One last question. What about ischemic stroke? So you gave the chemo, and your patient has presented with an ischemic stroke 3 days, 4 days, 5 days after a chemo. Dr. Sirish, uncommon situation or a situation which you have faced, that post chemo patient develops ischemic stroke, and again it qualifies as one of the thrombotic risks.
Yeah, occasionally it just comes once in a blue moon, and usually I refer to my physician person. So I think antiplatelets would be the one for that.
Yes, madam. So antiplatelet or anticoagulation or both?
Antiplatelet is one thing, but if the patient has received, for example, platinum-based therapy.
Yes, so that is the common. Patient has received paclitaxel, carboplatin,
do an ECG,
stroke.
do an echo, rule out a cardioembolic source, rule out a DVT, there could be a PFO, there could be merantic endocarditis.
Correct.
So cardiac evaluation is important, and sometimes when a scan is done, you will find an aortic thrombus here and there, and that will need anticoagulation. So anticoagulation is antiplatelet if you have a proven thrombus.
Correct. So stroke is diagnosed, and yes, you found a DVT in the patient.
You should not be satisfied that
now
stroke is
let us say that you found
cause.
a DVT in the patient. So madam, would you be sort of happy to start the patient both on anticoagulants as well as antiplatelet?
Yes.
Or only
no,
sort of
single
one?
antiplatelet with LMWH is a done thing, well accepted.
Okay.
DAPT is an issue.
No, not DAPT.
DAPT is not
Yeah.
only single antiplatelet.
Okay. Now last question for our intervention cardiologist. What about post PCI and your cancer patient? So suppose there is a patient with active cancer awaiting surgery, but then he is being diagnosed with a critical, having a critical arterial disease, and patient needs a PCI. You did a PCI. Now, how comfortable, sir, are you with the DAPT and the bleeding risk of this patient? Because patient has a cancer. So, what is your practice for DAPT in cancer
have a bleeding
patients?
avoidance strategy in cancer patients. If I can get away just by doing a drug-eluting balloon, I'll be happy, because that takes only a single antiplatelet. And if at all we have to use a stent, then of course we give a shorter duration, usually not more than 1 month of DAPT, and then put them on anticoagulant plus single antiplatelet. Usual dose is apixaban and clopidogrel.
Okay.
After 1 month.
Okay. So I think with this we'll end the panel discussion. If there are any last remarks from any of the panelists, otherwise we'll close this session. Thank you.
A few things is like what Dr. Chandrakant was saying. So when you evaluate your patients, just insist on mobility and hydration. Hydration is one very important thing, because many times the patients are dehydrated. Yeah, stalking as such not regularly used. Another thing is in patients with a single isolated subsegmental B frequently will be reported, go back to your radiologist if required, do a CTPA, confirm and then only start anticoagulation. That is like, because it's a radiological finding. Sometimes you get it reviewed and they'll say, oh, no, may not be there. Because 6 months of anticoagulation is involved. So be sure before you start. It should not be reflex. Sometimes it's a tumor thrombus. So we frequently have a conversation with our IR, is this a tumor thrombus? We question every time. So if it is a tumor thrombus, you have to be careful.
Yes, so
you
there
may
is
not
no
want
role
to
for
treat it.
anticoagulation in a tumor thrombus.
There
This is
is
also
a-
something that we must
That's a
reiterate.
very debated area.
Yeah, yeah.
How do you differentiate between tumor thrombus and
So this is a radiologic. Sir can tell.
In a subsegmental artery, it can be difficult because you're talking of a very tiny area. But suppose if it's a segmental artery, then you can see whether this is vascularized. A tumor thrombus will be vascularized, whereas a bland thrombus will be avascular. So if you show enhancement, then it is likely to be tumor thrombus. Also, you will get from the spread of disease elsewhere, right? It is very unlikely that curative intent disease will have tumor thrombus. So in the context, you'll also have to use the context.
Thank you. Thank you, panelists. And with this, we come to an end of this conference. So